Something, yeah, and then it's gone.
And I didn't know any plans for the midterm.
Yeah.
What's the midterm last year? Did really good.
Yeah.
After this, you say for this, right?
And just grab a cup and drink.
That's 15 different. So it's
Yeah, I think what this is.
I think we can start.
Yeah.
So most of the people here, I mean, he doesn't really need an introduction, but for people online and people from CASA, just let me say that we recently joined CASA as a research fellow, working on the Smart City project as part of the new AI for Collective Intelligence Hub. She has just completed her PhD at the Center for Medical Image Computing in the Computer Science Department here at UCL. And today she will talk about some challenges of applying AI in the healthcare domain, given her background, as well as other endeavors relating to AI and her work here at Hub. So be the floor is yours.
Thanks, that's a nice introduction. Okay, so welcome everyone. So it's titled From Brains to Buildings, and hopefully that's going to become clear why. So I'm going to be talking a bit about what my background was in before I came here. So maybe a bit different from the usual CASA seminar, because I'm going to be talking about dementia research. So, place to work. Here we go. Okay, this is obviously the people in the room can see my face in person, but for those online, if you don't know me, feel free to come find me in the office to have a chat. So thank you for the introduction. So I'm joining as a research fellow. I joined about 2 months ago. So I'm working mostly with Adam and Adham on the artificial intelligence for collective intelligence project and looking at smart cities. And before that, my PhD is also from UCL, but from the computer science department. And I've literally just finished. I got my corrections approved yesterday. So, and this was in computational modelling of dementia. So I'm going to talk about that a bit more in a moment. So just to start off with, I'm going to be talking about my sort of journey to CASA and then a little bit about what I'm going to be doing here. So I thought I'd start off by saying my undergraduate was in a slightly different discipline again. So that was in mathematics. So I went to University of Warwick to start with, and following my degree there, I came to UCL to do my PhD. So I've been at UCL for quite a while now, coming up for about 4 years. And it was in the Centre for Medical Image Computing, which is quite a big interdisciplinary centre here at UCL. And it's sort of embedded within the computer science department, but then has overlaps with other disciplines too. And my PhD was very much applied to dementia research. So a lot of work was with the Dementia Research Centre, which is another large institute here at UCL. So my PhD, this is the title, it's not very exciting. Computational modelling of symptoms, biomarkers and care needs in the rarer dementias. So what does that mean? So I was primarily looking at machine learning models. So mostly models which were unsupervised or had kind of like a probabilistic aspect to them. And then applying these to rarer dementia data sets. And I'm going to talk in a moment about what I mean by rarer dementia. So it was quite a mix of data sets. So a mix of neuroimaging examinations. So the sort of examinations you have after visiting a doctor. And also some surveys. So surveys collected from carers and people living with dementia as well. So I said it was applied to the rarer dementias, and so I'm going to talk a little bit about what I mean by that and what dementia is. So dementia is actually a really big umbrella term. It refers to lots and lots of different conditions. So it means basically any neurodegenerative condition which is affecting the brain and is getting progressively worse. So the main type of dementia is Alzheimer's. I think this is the one everyone in the room will have heard of. And they're often really conflated with each other. So people think dementia is Alzheimer's and Alzheimer's is dementia, but that's not the case. So Alzheimer's accounts for around 60% of all UK dementia diagnoses, and it has some sort of stereotypical attributes. So the symptom mostly is memory problems, so initial forgetfulness, forgetting people's names, that sort of thing. It's pathology, so what's actually causing it in the brain is, I say caused by protein buildup of two things, amyloid and tau, but actually we're not still completely certain what's behind that. So that's our best guess, is we think it's these two things causing it. And what they do is these are proteins which naturally occur in our body, but when we have Alzheimer's, they sort of accumulate in the brain. And it means the different parts of your brains can't communicate with one another. And hence you start to experience these memory problems. So what does it do to the brain? This is the neuroanatomy part. So it causes atrophy of the brain, which means sort of general shrinkage. So the parts of grey matter, the like lumpy bit inside your head, is shrinking over time. It's getting smaller and smaller. And then in terms of treatment, excitingly in the last few years, there's been some new drug treatments coming to market. So we're just starting to develop cures for Alzheimer's disease. So what I looked at in my PhD specifically is applying these ideas to rarer dementias. So rarer dementias make up less than 10% of all UK dementia diagnoses. And compared to Alzheimer's, they're associated with much more unusual symptoms. So things like language, vision, behavioural changes as well can all be symptoms of some of these more unusual rarer dementias. They also can be young onset, so that means being diagnosed before the age of 65 years. In some cases, being diagnosed in people's 30s, which is pretty bad, I'd say. They're also often inherited conditions. So if your parent has it, you have a 50-50 chance of getting it yourself. And the pathology behind it is a lot more complicated. Some will be Alzheimer's, but some will be caused by other types of protein buildup. Okay, so I want to talk to you specifically about this one type of rare dementia, which is called primary progressive aphasia. I'm going to break that down because something I learned is that doctors are a bit like Germans and they like sticking words together to make meaning. So primary means obviously the main thing. Progressive means it's developing in stages. And aphasia comes from a Latin root word, which means difficulty with language or speech. This is specifically a type of rare dementia which affects how you talk and communicate with other people. So people who have this, normally the initial issue is sort of talking to their loved ones. There's changes in how they communicate. So it's already quite a rare condition. Primary progressive aphasia is less than 1 in 20 of all UK dementia cases. But on top of that, there's 3 further clinical types to it. So it's extremely heterogeneous in terms of its presentation. So the first one is semantic variant, primary progressive aphasia. And these people struggle understanding the meaning of words. So they'll remember what a word is, but they won't know what the word actually means. Then there's the non-fluent agrammatic variant of primary progressive aphasia. And this one is a little bit closer in terms of disease to something like Parkinson's, if you're familiar with that. So it's more like a difficulty producing words. So you remember what the word is, but you'll struggle to actually say it. So you can't form the mouth movement to actually say the word. And then thirdly, we have logopenic variant primary progressive aphasia. And this is a difficulty finding words. So these people might get mid-sentence and realise they just can't find the word they want to say. Okay, so this is a little bit about the sorts of data I was using in my PhD. And today I'm going to talk to you specifically about just one part of it. I don't want to bore you for like hours with dementia research. So I'm going to be talking about how we use neuroimaging to do this sort of research. So specifically magnetic resonance imaging scans. So these are the scans taken in the big white loopy structure, uses magnets, and we can take a brain scan from that. And this is really useful because it allows us to see inside the brain whilst people are still alive. That's pretty important. And from that, we can start to think about how the brain might be changing with the disease. So this is what an MRI scan looks like from someone living with primary progressive aphasia. So on the left, we have the brain scan at first visit. And on the right, we have 12 months later. So this brain scan is taken front on, facing the patient, and primary progressive aphasia mostly affects an area called the left temporal pole. So the temporal poles, if the audience wants to take their hands like this, and if you place them above your ears like that, yeah, That's roughly where temporal poles are in your brain. So this is a scan front on, left temporal pole. So it's this area here. You see the increased activity. And it can be quite hard to spot. So this is looking over time how that area of the brain is changing. And it's quite subtle. So the research I was looking at is what are the neuroanatomical patterns which we associate with this disease? So how do we sort of identify different patterns of neuroanatomy from these MRI scans? And to introduce this, I thought we could play a little game of spot the difference. It's quite a dark game of spot the difference because it's about dementia. But anyway. Okay, so in each round, I've got 2 different brain scans and I'm going to ask a question about them. So round 1, which brain scan is the healthy control? So one of these is a healthy control, someone with no brain problems, and the other person has Alzheimer's disease. And Alzheimer's is general atrophy of the brain. So what that means is seeing more black areas of the brain. So who thinks the healthy control is A? And who thinks it's B? Yeah, you're all broadly right. The healthy control is A. Good job. Okay, round 2. Another round of which is the healthy control. So in this case, we have one person who's a healthy control, no brain problems. And the other brain scan is someone living with a specific form of aphasia. So you're thinking in primary progressive aphasia, it's going to look asymmetric. So thinking on the left-hand side, which is the right-hand side of the image, you might see some asymmetry. So this time around, who thinks the healthy control is A? And who thinks the healthy control is B? A? Oh, sorry, I'm doing this really badly. Let's have a hands up for A. And hands up for B. Actually, my notes are somewhere on my laptop. I think it's A. This is awful. I don't even know the answers to my spot the difference game. I'll come back to you a little bit later. I wrote it down. Final round 3, and I do know the answer to this one. So one of these brain scans has Alzheimer's disease and the other one has primary progressive aphasia. So we're looking for asymmetric differences in primary progressive aphasia and general atrophy in Alzheimer's disease. So who thinks the brain with Alzheimer's is A? And who thinks the brain with Alzheimer's is B? Yeah, it's A again. So this one, there's much more general black areas where the brain has shrunk in A. Compared to B, we see a more distinctive asymmetry across the 2 sides of the brain. Yeah, well done. You all did really well. I thought that was quite hard, so I'm impressed. Okay, so rare dementia research, it has some challenges. And one of the big ones is it tends to have quite small data sets. So these conditions are really low prevalence. We've already spoken about that, but they're also really poorly diagnosed. So in the UK, less than 2 in 3 people who actually are living with dementia will ever receive any type of dementia diagnosis. So it's rare, but then also you're struggling to get a diagnosis on top of that. And then on top of this, we also know that the rarer forms are even worse, so they tend to go undiagnosed. And then this is an issue across all of healthcare research, is you tend to have very biased data sets. The sorts of people who have access to healthcare, who are receiving a diagnosis, and then who are actually participating in clinical studies tends to be a very specific subset of the population and doesn't fairly represent the UK more generally, let alone a more global population. So coming on a little bit more now to the sorts of machine learning we use. So when we're looking at these sorts of very small data sets with lots of noise, problems in them, we tend to, at least in the healthcare field, focus more on classical machine learning methods. So things where we can think about the probability of different things. And specifically in my work, I was looking at basically looking at the probability of events having occurred with also clustering algorithms. So trying to probabilistically look at a likely sequence of brain change. So that's the probability that we see a certain sequence of events occurring in the brain. So that's sequence of atrophy. And then combining that with clusters. So we know in primary progressive aphasia, if there's not one pattern of brain change, there's actually many. So trying to understand those different patterns of brain change in the disease. This is the only slide with maths. I want to warn you now, and then it's done. So the work here was specifically looking at using something called the subtype and stage inference algorithm, which was developed by my old group. So basically, it's able to look at brain scans of people who have a neurodegenerative condition, and then identify patterns of brain change from these and cluster them to identify how these different patterns of brain change are occurring. So for each patient, the data set is the size of the brain regions. So we take the MRI scans, we segment them, normally using some software tool, and then the segmentation, we calculate the volume of each brain region, and then we calculate that region with respect to the entire brain size, because everyone has a different size brain, different head shape, you know, this sort of thing. And then we standardize it with respect to healthy controls. So we end up with a number for basically how much shrinkage we're seeing in each area of the brain. And then these numbers we use in our mathematical models. So the mathematical model in this research specifically was looking at the probability of seeing these certain sets of events given a potential sequence. So if we have a potential sequence that we think things are occurring in, we can calculate the probability of seeing that sequence given the data that we've collected. And then we are able to average this across all of the subtypes. And then we look at model fitting. So this was quite sort of classical machine learning, and model fitting was done just using a Markov chain Monte Carlo approach. So iteratively finding the best solution. So what sort of outputs does this have? Well, this is the research for my PhD, which is looking at identifying these different patterns of brain change. So here, what we found is that in primary progressive aphasia, there's 4 different types of brain change. So we know there's 3 clinical subtypes, but we actually found 4 different patterns of the neuroanatomy. So here they've been given names, so they make sense to doctors. So we have subtype 1, which is associated with the left temporal pole. That's what we already know is like the stereotype from primary progressive aphasia. Subtype 2, a different area of the brain, the insula. Subtype 3 is the temporoparietal junction, which is just above the left temporal pole. And then subtype 4, which is frontoparietal, so it's a little bit more front of the brain focused. And then beyond that, also able to then start thinking about how these relate to the clinical diagnosis. So is there a one-to-one correspondence between different types of brain atrophy and the clinical definitions? And this research suggests that no, there's probably not. So what we see in clinic and these sort of clinical definitions they come up with are typically constructed by doctors to make it easy to diagnose people in the clinic. And this can be very different to actual neuroanatomy and pathology we see when we start looking inside the body. So how is something like this sort of research useful? Well, there's been quite a lot of research coming on in this area of dementia in the last few years. And one of the things we know is that pathology starts to accumulate up to 10 years before you ever get any symptoms. So that means if you're getting a diagnosis of dementia from your GP, you've probably been having brain changes 10, 20 years before that diagnosis. So it takes a very long time for brain change to then show symptoms. On top of this, I mentioned earlier, we're starting to get some new drugs which enable us to tackle dementia, specifically Alzheimer's disease so far, but others are on their way. And what these drugs try to do is they are pumped into your body and they dissolve that buildup of protein I was talking about in the brain. But they're only effective if you inject them really early. So you need to give them to people before they start to exhibit symptoms. And so what this means is basically administering drugs before people have been diagnosed, which means we need a much earlier type of diagnosis. And this is kind of where the sort of brain research comes in, is if we're able to identify people who we think are likely to have these sorts of dementia, and then take MRI scans and identify early signs of change, we can then give them the right drug, but hopefully it means we can treat it. I promised I'd talk a little bit about some of the challenges of AI for healthcare. I thought this would maybe make it a bit more relevant to the more general audience. So I think there's two really big challenges when we use artificial intelligence in healthcare. So the first one stems from the data. So massive issue with privacy and ethics. It can be quite hard to get hold of healthcare data in a way that I guess it's not in the field of building or planning. Who holds this data, where you can use it, what parts of the data you're able to see is quite limited. Also tend to get quite small data sets. Some of the big open source ones are you do get some large data sets, but the sort of more smaller specialized data sets tend to be very small. And then on top of that, it tends to be quite biased. So as I was saying, the sorts of people who are being recruited in clinical studies and trials tends to be a very specific proportion of the population. On top of that, another thing I'd say actually is people tend to be quite protective about their data in healthcare. So often if people have accumulated very specific data sets, maybe it's related to a research group, they can be quite protective about who researches it, which can make things quite difficult. And then I think the other really big challenge of using AI in the healthcare realm is the translation. And I think this probably has some overlap with thinking about how the modelling we do here is useful for policymakers. So what do people want to see in order to adopt these sorts of models? So in the NHS, it tends to be very slow adoption for clinical use. So things have to be very rigorously tested. Doctors need convincing before they'll use any sort of AI model in the clinic. And because of that, I think there tends to be more of a focus on explainable AI. So things where you can put a PowerPoint together and explain it to the doctor. What's going on? What are the links? What's happening? And so there tends to be less of a focus on deep learning and that sort of research. And then I guess the goal is to try and find a solution which is able to span these two things. And I think that can be quite a difficult thing. Okay, so that's me done talking about my PhD. And I'm really sorry I'm going to talk about dementia a little bit more, because during my PhD, I decided to do a PhD placement. And I thought I'd talk about this a little bit because it's kind of the thing which bridges the gap between my PhD and CASA. So during my PhD, I became more interested in what in my old department was called engagement. So a mix of sort of outreach, science communication, but also thinking about the relevancy to policy. So I decided to do a PhD placement at a policy think tank called the Autonomy Institute. And they're a left-wing progressive think tank. So they were kind of spawned out of like the Jeremy Corbyn campaign back in 2019. And what they do mostly is policy work focused on the future of work. So trying to understand what work looks like going forward. And their really big flagship campaign is the 4-day working week. So you might have seen this in the news. Some of the UK councils are starting to adopt this. So trials leading to full-time adoption of people dropping down to working just 4 days a week. On top of researching about this, they also look at other areas. So inequality, climate justice, and also more broadly workers' rights. And the reason I decided to do a policy placement here is they have quite a big data unit. So they're very small, they're only about 20 people, but half of their team work on data analysis. So data analysis, economic analysis, and also using machine learning. So what I decided to look at here, and maybe it becomes clear how this sort of bridges the gap to CASA, was looking at regional variation in dementia diagnosis. So when I joined the Autonomy Institute, they just started looking at building essentially data sets of inequality in the UK. So trying to look at sort of factors in terms of annual deprivation. And I thought it'd be interesting to look at whether these data sets could be used to see what the regional variation is in terms of who receives a dementia diagnosis. And I think this is interesting because we know there's patterns to who receives a dementia diagnosis. It's not random. It's not a random 2 in 3 people everywhere across the UK. So we know there's much lower rates of dementia diagnosis in rural areas and in deprived areas. Areas with a single-handed GP practice. So that's a GP practice where there's just one GP at it, which you tend to get in rural parts of the UK where it's very remote. they tend to have a much lower rate of dementia diagnosis. And then on top of that, we know you're less likely to receive a differential diagnosis in more deprived areas. So the differential diagnosis is a really important part. So how it works in the UK is you go to your GP with memory problems. They might suggest you have dementia, but what you need is a referral to a memory clinic or hospital. For example, the Institute of Neurology here at UCL. And it's only then that they're able to give a differential diagnosis. So they can say whether you have Alzheimer's disease or something else like progressive aphasia. So briefly, this was also quite exciting because it was first time using bigger data sets. My PhD used really tiny data sets, and I don't know how to tell you, that's pretty miserable. Big data sets are a lot better. So this project was mostly looking at using a mix of NHS datasets and datasets from the ONS. And then just using very simple models, just looking at multiple linear regression models with a bunch of different covariates to try and understand what affects who gets a dementia diagnosis. So can we understand what the linking factor is here? And it was quite preliminary work, what went on. So this is kind of the main output from the work, was just trying to identify what areas of the UK might be underdiagnosed the most. So are there specific patterns as to what areas, and what are the covariates which might be linked to this? So these are the 50 local authority districts identified as most vulnerable to potentially underdiagnosing dementia, which I looked at just from analysing the residuals from the linear regression model. And then also looking at the covariates with the largest coefficients in the linear regression model, and then finding links. So the main link tends to be age and gender, which we already know. So the older you live, the more likely you are to get dementia, sadly. Yeah, so finally coming on to CASA. So the last step in the journey up to now. So I'm employed here as part of the AI for Collective Intelligence. So this is a really big multi-hub grant. So it's based out of Bristol, but spanning lots of different universities. And we're working here on the Smart City scheme. So Adam, and me. And then there's also the team in Glasgow here. So this is our recent visit to Glasgow for the Turing Institute Data Analytics Workshop. Not nods in the audience. I got the name right. That's good. Okay, so what we're thinking of looking at, and it's quite early days of the project, but starting to think about sort of the issues of housing supply in the UK and specifically in London. So what is being built and what are the problems? What's not getting built? So there's been some quite ambitious targets coming out from the government about what they want to build, where they want to be building new homes, new towns, and then what are the issues here? And a big focus has been on issues in the planning system. So there's too many delays, things are getting held up, things aren't being approved to then get built. So really this is where the analysis is starting, is trying to look at understanding what residential housing is being built in London. So what is being built, so quantity, type of residential unit being built, where are these units being built? So trying to understand, geospatial nature, where they're located, and then how does this relate to the government targets? So these are the very latest targets. So the Labour manifesto, I don't know if it's a manifesto, but it was more recently than that, I think. So they said they want to build 81,000 residential units per year in London, which is quite a lot, that's high. It's down on the last government's promise, which was 99,000 a year, which was particularly unrealistic. And on top of this, we also have the London Plan. So this is the guidance set out by the Greater London Authority. So they're saying 6,000 units per year, but at least half of them need to be affordable. And they define affordable quite broadly. So affordable doesn't necessarily mean council housing. It means anything which has some reduction. So it could be things which are being rented at 80% of the market rent, which is still quite high. So we're looking at this using the London Planning Dataset. So this is a really big new dataset, and it's quite new-ish from the last few years. And it's hosted by the Greater London Authority on their website. And it's quite big. So it's meant to be all of the planning applications which are coming in are being fed into this one sort of big general London data set. So it has over 1 million data entries, but they tend to be quite recent. So we see sort of 3/4 of this is since 2010. So there is some historic data actually going quite a long way back. There's some entries from the 50s and 60s, but mostly this data is very recent. So they're updating this data set and it's growing. And then since 2010, we have about 79,000 residential applications. So these are applications for any sort of residential unit in the city. The promise is it's being updated in real time, but I don't know how true that is, honestly. I suspect there's a bit of a delay, but I think you'll see that in the graphs in a minute. So this is what I've been doing so far, is just trying to understand some of the attributes of this data set and what's being built. So this is the first thing I was looking at, is trying to understand the scale of what's being built. So what we're seeing in London is that large units are starting to contribute a lot more to supply. So on the left-hand side is a comparison. It's quite small. So in blue, we have residential projects applied for, or permitted, sorry, I should say, which are between 1 and 50 residential units in size. So quite small scale building projects. In red is over 50. And then on the right, same graph, but blue is 1 to 500. So 500 is quite a big project. So in red, these projects which have over 500 residential units within them. So what we can see is basically since 2000, and there is an issue here, is that we might not have sort of a full picture of the data set between sort of 2000 and 2010, but there seems to be a trend that these large residential projects are really starting to contribute massively to what's being built in London. And we see that a little bit more clearly when we look here. So I'm really sorry, this is not very clear, but it goes from 1 down at the bottom here in blue. So that's actually pretty stable, the number of people building single homes. So probably self-builders is quite stable over time. But then this number, sort of once we look at building projects of over 200 residential units, it's really starting to overtake. So much more of what's being built in London is coming from these very large scale commercial projects. Starting to think too about where these might be located, and I think this isn't particularly surprising, is we start to see sort of a trend. There's a lot being built in this area of East London. So this here is the Olympic Legacy site. So massive concentration of housing in that area. And then also starting to look at what types of things are being built as well. So these are the targets I was just talking about. So at the top, we have the target from Labour, and then we have the London Plan 2021. And then this is the barrier for affordable housing. So if they want over 50% to be affordable housing, we need anything which is purple or lilac coming up to this line here. So it's falling massively short. I mean, in 2023, the number of permitted residential units was barely 40,000. So way, way below. And this is just what's being permitted. This isn't even what's being built. So a fraction of these will have actually been constructed. I think maybe around like 80% will ever be constructed and reach completion. So that's kind of where I'm at so far in terms of this analysis. So the project's called Artificial Intelligence for Collective Intelligence. And a big part of that is going to be talking to the project partners. So we've started some of this initial analysis, but we're really keen to understand what they're interested in and what they would want from our sort of work. So we're working with Greater London Authority, also the Ministry of Housing, Communities and Local Government, and then also some of the different boroughs in London. And yeah, we're going to be talking to them in the coming weeks to really try and understand what is useful for them. And that really brings it to an end. That's everything I have to say. Please, any questions about dementia or otherwise, I'm happy to try and answer them. And yeah, if you want to contact me, this is my email address.
Do we have questions?
Do you actually have any data on completion?
Yeah, I started looking at this. So they're meant to be recording in the same data set when projects are being completed. And I think it's not very up to date. So it seems like they're encouraging the boroughs to update completed status on a yearly basis and then feed it into this data set. But I think it's very, very patchy. So I'm starting to look at alternative data sources.
We'll have a word afterwards.
That'd be great.
Yeah, so just on that, I did lots of housing research, and the energy performance certificate is probably the best.
Yes.
I've just published a paper on the last 15 years of development around London, so I'll send it to you if you want.
That'd be perfect.
But just a couple of things that'll probably come up. So one will be,
Yeah.
So the Greater London's got the London Development database, really good data, but it is very much regional, the housing demand. So that would be one thing to think beyond there. And then, the land availability is probably the biggest. So you mentioned that housing delay was quite often to do with bureaucracy and planning discipline.
Yes.
Land availability is the biggest constraint in London. And when you showed your map earlier on, that maps perfectly with opportunity areas from the London plan, where land and brownfield is available. So that's the big arguments how to release more land.
That's really interesting. Is this to do with, I was reading that Deep Khan saying very much prioritising brownfield sites, and now they're saying they might expand to greenbelt.
But we've kind of run out of the best brownfield sites, unfortunately, because you see all the docklands and stuff. So yeah, there is a lot of greenbelt land, both in outer London, but also the wider region as well. But it's a bit of a risky balance to strike.
Is that something you've looked at? Sorry, I'm asking you the questions, but I was thinking about this. It would be interesting to see what's being built around the periphery of London as well. Is that something?
So what's great about using the energy performance certificate data,
Yes.
it's the whole of England and Wales. It goes back to 2005. It's only completions, but it's really, and it's address level as well. So it would match up quite well with your other data set.
Okay. Thank you.
If you have a problem building on the outside because of likely to push people into areas of low accessibility.
Yeah.
And we've had some very unsuccessful housing estates. So it's not just availability of land, it's availability of use.
Yeah. That makes sense. Yeah, where's accessible to central London?
There's a big data set called the planning portal, basically, which where if you look at the planning portal, you can identify that there's something like 750,000 planning applications per year in Britain, and this is, I mean, it's not completely clear, but about 90% of all planning applications in England and Wales. I'm not sure whether it covers Scotland, the planning portal. I think it probably does. These are all recorded, and this is organised by the ministry to some extent, and also by the RTPI. It seems to me that one possibility would be to filter that data with respect to the GLA area. So because I guess you can't, I mean, we looked at it when we did our task force thing, we looked at the planning portal, and quite frankly, it was simply too big to do anything with. You know what I mean? There's too much data, basically. And I don't know how easy it would be to contact them and to actually filter the data in some sense, because obviously if you can filter it for GLA, you can filter it for anywhere. So some of these areas, like Duncan was mentioning, around the edge of the metro area, basically, could be picked up, really. So it's worth sort of spending 5 minutes thinking about whether there's anything in that might actually augment, your study of the GLA data.
Yeah, I think that could be really interesting.
And I think that, I mean, this is not just data which is just a count. There are many attributes of the data set, I think, which could be pulled out. I'm not sure they're very different. They're different or more than the GLA data you've got. They're probably the same in some senses, but nevertheless, the attributes are quite useful.
Yeah, that sounds good. It's quite a rich data set. the GLA one, because it also has pretext associated with it, which is something we haven't started looking at yet. But
Mark Tudor Jones is worth talking to, I think.
Yeah.
About this, yeah. I think he knows quite a bit about it. Yeah.
good.
Sorry, I was wondering, do you have any intentions of looking at rejections as well as
Yeah.
things?
So this is
That'd be really interesting for me to learn about.
yeah, this is linked. Is something I was thinking I'd like to look at is looking. So they give a free text response of why applications have been rejected. And I was thinking that would be quite interesting to pick out the themes and see if there's repeated things. Because what we've been talking about is looking at whether applications meet the London plan. So are they just being rejected because they don't align with the London plan, or for other reasons as well?
First of all, thank you for the presentation. It's fascinating, and my PhD was also in housing development in a different city, but it's amazing how no matter what you say, everyone's got an opinion. So be warned as you go with this project. But I'm curious a couple things. One, if you're using or looking at the political aspect of this within the GLA, because I recently completed a project that involved interviewing a lot of GLA assembly members about a number of things, but housing came up over and over and over again.
Yeah.
Unsurprisingly. So there's this whole sort of political discussion about what's being built, where it's being built, that is somewhat related to sort of opening up land and the controversies that I've already mentioned. But I'm just curious whether that sort of factors in, because I think the shaping of that London plan is political. And then if that's really impacting planning commissions, that sort of aspect of it could be really essential to understanding why some of this is happening, or why some permissions are being granted and aren't. So that was one question. Yes, if you're looking at the political aspect. And the second question I had was whether you're also, so something I found in I was looking at housing in Zurich, but that the demolition data was actually really critical. It was a confounding variable in a lot of understanding sort of what kind of housing was being built, because it wasn't factored in often. And it really made a huge difference because a lot of housing was being built where housing was being torn down. So I didn't know if that's something that you find in the data set, or if you're able to look at that.
Yeah, so the data set is, I'll answer the second first. So as I understand it, it records, yes, it's slightly different. They have to record residential units lost as well as residential units gained. So yeah, this is something I'm going to be looking into, is checking sort of what's being recorded in the database in that respect. About the first question, I think that'd be really interesting. And we haven't really talked about it yet. And I think it would be interesting, I think, talking to the GLA as to what they say about this and what that angle is. Honestly, yeah, I don't know, but I think it could be an interesting direction to take the project in.
Yeah, it was really interesting to see, because it's basically every assembly member I talked to, it was like build.
Yeah.
Was but depending on the party, what that meant and how it should be implemented was very, very different. So there were some pretty significant differences of sort of how they thought that build should be executed. And also, I guess I was also curious about the new towns kept coming up over and over again as a sort of political project as well. And I don't know if that's part of what you're looking at, or it's sort of outside the scope.
No, I think it'd be really interesting. I feel like there's been quite a lot of criticism recently of basically the planning system failing to approve enough builds. But looking at data, I'm not sure that that's really the case. It seems like there's just a lack of building too. Seems to be a big part of that.
It's never been the case.
Yeah. So, okay.
There's always been an excess of unfulfilled planning applications.
Mm.
That's all over the country.
I think a lot is to do with house builders. I mean, my own view is that the housing crisis in Britain is not to do with the planning system. Well, yeah, of course, builders have to get approvals, that in that sense, but it's more to do with the nature of the building industry that we've got. It's a bit like Britain and supermarkets, for example. We've got like 5 big supermarkets that have so much percentage of the market. Very, very different from places like the United States and Germany. It's the same with house builders to some extent.
Yeah.
And, you know, they have their own behaviour, which is, you know, hoarding land, all this kind of stuff, basically.
Yeah.
I'm not an expert. There's lots of people who are experts on it, this sort of stuff, but that strikes me to be a big part of the problem, really.
Yeah.
You know, rather than trying to improve the planning system, which I think it probably does need to be improved in terms of speed of things. But it's not just, I mean, if you criticise the planning system, you've got to criticise the national health and, blah, blah, blah. So in some senses, this issue needs to somehow be factored in, I think. But I don't know whether it's part of this project, but probably finding out about the building industry as part of this might be quite a useful sort of take on it. It might be a useful dimension, really.
I agree completely. I've done quite limited analysis so far, but it does seem that it goes beyond an issue in the planning system, that there is this issue of just a certain set of people dominating what's being built.
Yeah. Definitely that's the case, but also their behaviour is changing. So a lot of, because of the depression in the housing market, despite prices going up marginally, etc., the returns are much riskier.
Yes.
And so now you get a lot more public-private cooperation. So you'll find local authorities are building housing that's been built by one of the big construction companies.
Yeah.
So that's quite helpful. But it still doesn't get over the problem. A, they're not getting enough affordable, and B, that affordable isn't affordable.
Yeah, completely. I've read some anecdotal reports from this year saying some of these large-scale developments are struggling to sell all their units, and local authorities are buying them out and turning them into affordable, and this sort of things happening.
Yes, local authorities have their own agenda as well, in the sense that they're buying property as income generation because the government has taken all their money.
Yeah.
And that's been going on for a long time. When you see these days one party or another claiming, we have huge levels of development, which is true, but a lot of it is still basically council. It's being built by developer in partnership. It doesn't necessarily count as local authority development.
Yeah, definitely. It's something quite hidden in the data like that.
There are a couple of questions in the chat. First one is more perhaps of a suggestion from Duncan. It's, have you looked at the ForYourLondon.com dataset? CASA worked with them a few years ago, and they, okay.
Yeah, we haven't looked at getting access to the data set yet, but me and Adam were talking about them. So they're a private company who are, they basically try and record what's being completed on large scale projects in London. But it's a private data set, it's a sort of pay to access one.
And the second one is, you briefly mentioned that it would be nice to see what is being built around London. I was just thinking about asking if the proportion of affordable homes in London for GLA's London Plan targets are for London boroughs only. And if you are planning to look at within the M25 as a system one day, affordability levels could potentially be different in areas formerly outside London. That could help meeting what is set. Obviously, with questions on infrastructure, etc., and accessibility, but that's a different story and probably not in the strict interest of GLA.
That's really interesting. Yeah, I think this is kind of what I was saying, but maybe it needs to look beyond just the boundary of the GLA. So I think their promise of 50% affordable is 50% affordable being built inside. So it clauses in the London Plan that you can't build 200 units and then build 100 of them somewhere else outside the city and say these ones were affordable. So there are clauses to kind of protect that, but it'd be interesting to see. Yeah, sorry, more questions.
I had a question about the dementia research.
Yes, okay. Yeah, great.
I was interested in specifically the work you were doing while at the Autonomy Institute, where you were looking at different factors associated with diagnoses. And you mentioned sort of a set of factors that are associated with having dementia.
Yes.
And a set that might be associated with, given that you have dementia, getting an accurate diagnosis.
Yeah.
And I was wondering if there are sort of statistical approaches to teasing those two things apart, or if that would require like ground truth data on undiagnosed dementia cases, which I guess is difficult to find.
Yeah, this is such a good question. So this is kind of what we were hoping to achieve, is to understand what separates those two things. And there's not really enough data on it, because what you have is basically just the raw number of dementia diagnoses from a GP. And you only have them at the level of a GP practice, LSOA, not on an individual level. And the sort of analysis I did there was quite limited. I was there for a few months, but this is, I think, is actually a really interesting question. And I think it's difficult because there's a lot of confounding covariates in math. So, for example, educational attainment. People with high levels of educational attainment are actually more likely to get dementia in some ways, because you tend to live older because you're not getting other conditions. So the people in this room actually will at a slightly higher rate of developing dementia, because we're probably not going to get other health conditions which will kill us. Sorry, bad news. But then also areas with high educational attainment tend to be wealthier areas, better healthcare provision. The NHS is a massive postcode lottery. It's not equal across the UK. Where you live massively affects it. So that also factors in. They're more likely to get a diagnosis. So yeah, I think it's really interesting. I don't know how to look into it.
Yeah, makes sense.
Just curious if there's any kind of finance information database, because I think the two issues are usually like land to build on and money to build with. And I'm curious if there's any sort of.
Yeah, within that data set, there's not.
Yeah.
But it could be looked into, because every entry on the data set should link to a planning document, like the actual PDFs submitted as part, and then they would have financial information in them, I think. So I guess it could be linked.
Any more questions? If not, it's almost 2 o'clock. I will stop here and thank you once again.